So to start off, as Vicky said, I'm Liz Lee Thackeray and I am Children Adult Safeguarding Named Nurse. So I thought I'd just start by saying a bit about me, because there is some people that don't really know my background. So 28 years I've been a learning disability nurse, and I think that I'm really glad I chose that career path actually, because it's given me lots and lots of different opportunities. I did 10 years working with vulnerable adults in different settings, so I've worked in forensics, assessment and treatment and residential, and then I had an opportunity to go into school nursing because I fancied working with children for a while. And that gave me an opportunity then to go into CAMHS, so I would say that was a real turning point in my career, because we set up a CAMHS service from scratch for learning disability in Rotherham, and that service had not existed before, so that was really a real opportunity. So within that time I became a prescriber, and I also did a master's, because I intended to prescribe for children and work alongside a psychiatrist, and that's the way that I thought my career would go. However, at the same time I was a lead for safeguarding in CAMHS, so that meant that I provided training, supervision for all the CAMHS workers, and supported them when they had to go into case conferences. And I had a real passion then and realised that safeguarding was actually a route that I wanted to take. So I had an opportunity to move into secondment as a named nurse within a mental health trust, and that was just for safeguarding children. But I realised then that that's really what I wanted to do. But however, CAMHS had spent a lot of money on training me up to be a prescriber and stuff, so they wanted me back. So I ended up in Guernsey by running, literally, from having to go back in a CAMHS direction, because I'd done about 8 years and I just had enough. So I came over to Guernsey almost 6 years ago, which has absolutely flown. And I came here to manage a service for short break for children, but really wanted to get back into safeguarding. So when the named nurse position came up, I jumped at that. So I get asked quite a lot about the named nurse, about the title. People seem to think, what's it mean? What is a named nurse? And that title comes from UK legislation where these roles are statutory. So you would have named and designated professionals that sit within every clinical commissioning group in the UK, and those of you from the UK will be really familiar with that. So we've got myself, named nurse, we've got a named doctor for children, Sandy Bowen. We will be getting some designated nurse cover going from next week. We'll have 6 days a month, and we're also going to be getting an interim designated doctor for 2 days a month, which is really exciting. So there's lots happening with those named and designated professionals. In Guernsey it came about because we had reviews, such as paediatricians came to review us, and they said it's a real risk that we haven't got named professionals in health for our organisation. So such as like adult safeguarding was on the risk register, and we recognised that it was a risk. So that's how my post came about, and it was in development for a lot of time before it was actually agreed. So just a bit about named nurse function and what I'm working towards. So this is a safeguarding assurance framework, and this is what it looks like, and this underpins all the work that I'm trying to achieve. So what I'm thinking about is, have we got a safe and effective workforce? So that's thinking about all our health staff. Are we trained up? Are we accessing good training? Is the training of a good quality? Are we accessing supervision? Because it's really recognised that anybody working in child protection and safeguarding in particular should access robust restorative supervision. So that again is something that I'm really focusing on. A lot of my role is about being available for seeking advice and support, but what I want to say right from the start is that I don't interrupt process. So people don't come through me to make referrals. The processes are there for adults and for children. So we've got children's MASH, we've got adult MASH and adult safeguarding, all based at Perouk House, and those systems are in place. So my post referrals don't come through me. People can come and talk to me for advice and support, but you don't wait to speak to me if you need to make a referral. So I just want to be really clear about that. So the thing about supporting staff as well is making sure that all our staff can recognise safeguarding as it arises, and that's what gives us a safe organisation, when we've got people that can recognise what's happening and now they know how to respond to that. Partnership working is absolutely key. So I will working with all agencies, because we work with children and adults, but we've got lots and lots of different people working with the same families, and now we're working in partnership. So again, I see my role as absolutely key to partnership working. So I work really closely with the team at Perouk House, the safeguarding team, but I also I work with the people that go into the MARAC for domestic abuse. I work with probation for the MAPA for offending, and support all those professionals and work with them. And I built those links up first, so that's the first thing that I tried to do in this post, really. Another key part of my post that I see that is when we have a serious incident in safeguarding, or even, God forbid, a death of a child, we might have a serious case review, or we might have an investigation. From that, we will always get an action plan. And that action plan, a key part of my role is making sure that the actions from that, I take them forward, and whichever health professional or organisation, that's down to me to make sure that they're going to implement that. So such as like your high profile cases in the UK, such as Daniel Pelka and Baby P, everybody will have seen those, and from that you'll always see we need the lessons learned, lessons. That's what it's all about, embedding, and that's why it's really key that we have safeguarding, serious reviews, and that we investigate things as they arise. So that's the whole assurance framework that I'm open to work towards. So when I came for this post, I was asked, for my presentation, I was asked to think about what challenges there might be and what opportunities there might be. So I usually look at challenge that it gives us an opportunity, because we need to be creative when we're challenged. So I'll just talk about a few what I identified at the time. So the first one that I came across, let's face it, children and adults is huge. This position, it's a huge job, it's a big job. And even though we can apply lots of principles of safeguarding to both, we do have differences. So like with children, you've got your 4 categories of abuse, but with adults, you've got extra categories where we've got modern slavery, we've got organisational abuse, we've got financial abuse, so you've got more complexities. And it's really important that I can understand policies and procedures for both, and that I'm confident in my knowledge in that, so that I can make sure that people are working in health are also confident about that, so that the scope of it, it's big. So I say loosely that it feels easier to safeguard children and keep children safe, but it's never simple, so I say that very loosely. When it comes to adults, I find the adult safeguarding really complex. I think when you've got a situation where you've got a risky adult taking, decisions that are risky, that are dangerous to their life, but they've got full capacity, it's really difficult to keep them safe. So like capacity and consent really complicates adult safeguarding. And I think also, thinking about domestic abuse situations, if you've got a child within a domestic abuse situation in a family, you've got the power to be able to, at an extreme, remove that child if they're really being exposed to emotional harm. But if the adult decides to stay, there's very little that we can do to protect that adult if they make that decision to stay. So I feel that we've got really robust procedures, but safeguarding adults is so much more complex. So the other thing I thought about is, like, one person getting across everybody is really challenging. So if I've not got to see you yet, apologies for that. I've really tried to spread myself quite thinly this year, but I'd like my profile to be raised in a queue. I am based here, but I do go out and about quite a lot. And just like everybody to know that I do try and reach out to everybody. I have been to Alderney, and Alderney is quite scary in that we've got increasing elderly population, so immediately you've got vulnerability straight away because you've got that elderly population. And the win-win, that's about the partnerships, that's about making sure that within this I've got really good strong partnerships within every area, because I do have to spread myself out. So we've already got quite a lot of links from the adult safeguarding within each area, like learning disability, older adult mental health. So for that, it's really good for me to utilise those links already, so that I can spread myself out. So just to talk about a bit of boring legislation. One of the biggest challenges for me and for people coming from the UK is that Guernsey legislation is different to the UK. So in the UK, for children, we've got working together, and this is the Bible in children's safeguarding. Named nurses carry this round under their arm every day, and when a new edition comes out, we get really excited. So I don't know, but we read it cover to cover, and that legislation is statutory. So it means that everybody has to work to that legislation. Over here, we've got Guernsey law. So we do try and follow working together, but it's not statutory for us. So child protection procedures are really different over here, and I think it's important for us to recognise that when we've got people coming in to our workforce from different areas, that they really understand that our processes are different. Particularly our convener system, it very much follows Scottish guidance for child protection, and that is very different to what people might be used to working with in the UK and other areas. So, and when we think about adults, safeguarding adults as well, we've not got some of the laws that they've got in the UK. So for domestic abuse, we've now got coercive control law, we've got stalking and harassment, and they are quite recent in the UK, but when you get domestic abuse, it gives us more powers as safeguarding professionals to be able to make some changes and to protect people. When we don't have those laws here, we have to be more creative, and that is why it's so important that safeguarding professionals work together. Something else we've not got in Guernsey as well, we don't have modern slavery law. So, and I do think that there might, you'll have seen the UK, you'll have seen the recent stuff about people being transported into the UK legally. I think we're a small island, we're quite, we're out there, and I think we could say that this is happening here as well. We don't have the laws, but it's recognising if it's actually happening. So, and just to talk a bit about our safeguarding structure. So this is going on to next year. But our safeguarding structure here, we've got equivalent to local safeguarding children's board, we've got a children's partnership board, and we've got a new chair, Sarah Elliott, and she is a Pan-Island chair, so she'll be working with Jersey as well. So that's really good for our links with Jersey. We're hoping that we're going to be able to tap into some of their stuff, so that's really positive. And Sarah's also tasked with setting up an adults board. So this time next year, I'm really confident that we're going to have an adults board as well. So again, that really strengthens our safeguarding adults within Guernsey, so that's really positive. So just to talk a bit about what I've been doing over the last 10 months, which has absolutely gone in a flash. So I've been thinking mainly about what do we need for foundations in good safeguarding in health for all our health professionals. So I've been looking at scoping out training and supervision, because they are what underpin everything. When we've got a well-trained workforce, that's the vehicle for having safety. And when we've got staff supported through good supervision, good restorative supervision, again, it's safety. There's lots and lots of research about how good supervision is, that it's needed, particularly for our colleagues working in child protection. Everybody knows that work is really stressful. So when you can come into your supervision, you can have one-to-one or group, but it's just that opportunity to be able to stop and think, where am I at with this case, reflect on it, and come out of that with a plan. And that's all about what supervision is about. And I could talk to you, I'm very passionate about it, so I could talk to you about that all day. So we've got the first 17 people trained up in supervision to be supervisors, and we've done that this year. And I didn't just limit that to children. I opened that up to adult learning disability, older adult mental health, ED and theatres, because safeguarding comes into every area. But also the skills in that training you can use in lots of different supervision, so it's not just about safeguarding. Those people are now equipped to be able to take those skills back into their own area and set up their own supervision. I've done a few safeguarding investigations as well, which has been really good learning for me, because it's meant that some of them have linked into some of our nursing and residential homes, so that's meant that I've had to go out into community and understand what differences there are there for us as well in Guernsey, so that's been really beneficial. And I would say that making the links is that feels like a real success, because I've got good links with the police, education, probation, third sector, Action for Children. I would say that I talk to them most weeks, so those links, I'm feeling like those links are quite strong now, and I'm feeling confident enough to come back in now and be able to signpost people when they need to, so that's been really beneficial for me. So what's next? I've already mentioned training. What I'd like to do about training, which will be in conjunction with it'll be in conjunction with the ISCP, who is our board. They have a coordinator, and they will look at all training for safeguarding children and adults, I hope. I'd like to think about us doing a Think Family approach for training, and that means that we'd have a one-day training that would cover children and adults, because families, it's about looking at a family and thinking what risks are there in that family, but what strengths and resilience are there in that family as well. So I'd like to think about a training that really meets health staff's needs, in that rather than having to come out for separate children's and adults training, I'd really like to have a think about that joined up training and pilot that and see what staff think to it and see if they think it meets their needs. So that's something that I'm working on. We've designed it, we're just waiting for the go ahead really. The other training I'm hoping to roll out is the domestic abuse, stalking and harassment risk assessment. I'm a trainer now for training other people to use that, and I'd really like all our frontline professionals to have that training, so that should somebody present in ED or coming out of theatre or anywhere, midwifery, if somebody decides to disclose domestic abuse, those staff are ready to respond by risk assessing and a safety plan and know what to do in that situation, and not thinking, oh, what do I do with this? So that's something as well that I'm hoping to do. The safeguarding supervision really want embedded, and I need to get the buy-in from managers so that they release their staff for sessions, but also support our supervisors to be able to deliver those sessions. So going forward, I'm hoping for another set of training where we can get even more supervisors trained up, so that we've got plenty of people and lots of resource across HSC, so that we can really get this embedded. So they're my main two aims for next year. I want to focus at safeguarding adults. I'll be basing a lot of my work on the Making Safeguarding Personal principles, which is about empowerment, proportionality, accountability and protection. Can't remember the other two. Contextual safeguarding, that's very much the buzzword at the minute in safeguarding, and that's about what's happening here in Guernsey. So to give you an example, I worked in Rotherham, and you would have had to be in at the North Pole to not realise, hear about sexual exploitation in Rotherham and what happened to lots of young girls. I worked directly with some of the girls, but then when I went into safeguarding, we very much had to work around strategies for trying to protect young girls. And we'd built up lots and lots of ideas and strategies for doing that, but then we had a change, and this is safeguarding is constantly fluid and changing. The challenges change all the time. So we had lots of Eastern Europeans moving to Rotherham that were Roma Slovak, and what came with them was a complete different challenge into safeguarding, in that what might be okay for their culture within their family is against the law and is child protection. So you're really challenged in being able to deal with stuff like that. So that is like contextual safeguarding. Now you adapt at that time to working with your challenges in that area. So for Guernsey, I think our contextual challenges are drug and alcohol misuse. I think that wherever you've got drugs, you've got exploitation, or the potential for exploitation. I think that we do have exploitation of young girls. I think that happens here too. It's not like thinking actually we're in Guernsey and that doesn't happen, because it does. I think modern slavery will be a challenge for us as well, particularly when we've not got the laws that we've got. And domestic abuse, I think, because we have such challenges with people needing to live on a licence, when you've got somebody staying in a relationship because they're on somebody else's licence, I think that's a real contextual challenge for Guernsey when it comes to domestic abuse. So all that, my aim with all of that is that we'll strengthen the systems and we'll build upon the systems we've already got in place. So like I said, I don't interrupt the process. My role is very much about strengthening what we've already got and building the confidence and expertise within health.
So I've been asked to come here today and tell you about how we have implemented SCAPE within learning disability practice in Guernsey. I've used this presentation in the UK, so I apologise for some of the slides that don't have much relevance. So this is just a quick overview of Guernsey. We've got approximately 250 adults with a learning disability known to services within Guernsey. Our existing services include 4 residential homes, 3 outreach services, 1 supported living service, 1 day service, short break, community learning disability team, and the newly opened autism hub. So we've got quite a lot of services for such a small island within learning disabilities. But when we were looking at the SCAPE tool and how we devised it, we had to look at how it fitted in with different frameworks and innovations in Guernsey. So we looked at how it would fit in with Safe for Every Day, if it followed the care values practice, and how it fitted in with partnership purpose. So we looked at why was it so important to develop this tool for Guernsey. I know you already know this, there are no independent inspections in Guernsey. We've got no one coming in telling us if we're doing a good job. There's no CQC, we don't know where we need to improve. The law system in Guernsey is very different to the UK. So we've got our own mental health law, we've got no Mental Capacity Act, we've got no Discrimination Act. So tools from England don't always work in Guernsey because we've got to alter them to make them work for us because of the differences. What is NAS? So, this confused me greatly when I first started hearing this term. We talk a lot about SCAPE in Guernsey and about how we've used it, how we've embedded it. So when we first started looking at how we used SCAPE, tried to Google it, doesn't really show much when we look at SCAPE because it's called the Nursing Assessment and Accreditation System Framework, the NAS. If you Google that, it comes up with a lot more, which I never realised. So earlier this year, there was a new guide that was developed called A Guide to Developing and Implementing Ward and Unit Accreditation Programmes, which was backed by Ruth May, and it tells you how you can implement your own nursing assessment and accreditation system. It also makes it clear in the document it's not just about focusing on hospitals, you get to look at other areas. So Salford, who we took the SCAPE from, has actually started developing their own community assessment accreditation system, their CAS. So they've taken the hospital model and they've made it fit in the community for them. In the document it tells you about 4 different examples of different trusts that have used it. One of them is Salford, who we took the SCAPE from. It's a really good little document and it just explains the assurance framework that we use. So what was SCAPE? Well, after we realised this is what Salford was using, it's used within nursing, but we can use it outside of nursing as well. And it's an approach to explore how care is considered, delivered, and then evidenced in relation to quality. We also look at the experience of people receiving the care, not just delivering that care. It's an audit that helps department and organisations develop an evidence-based high quality of care and support they provide. It's linked to standards such as the key clinical indicators and compassionate care, the 6 Cs, it's all linked together. We also go under the CQC guidelines, so we look at all those documents every year and see what's new, what's changed, how can we improve it. We did alter it for the learning disability tool and added more bespoke standards, so I'll go on to that in a minute. The generic SCAPE consists of 15 standards, ranging from organisational management, communication, the NMC code, care and support of people with dementia. It's all very generic, it's all very hospital based. Within the hospital, they are giving 24 hours notice before the audit. The audit team arrives at an allocated time within the hospital, usually a Wednesday from 10:30. A member of the quality and safety team are always there. They encourage other people to participate, and it's only really cancelled in extenuating circumstances. So that's what happens when they go into the hospital. So why did we in learning disabilities decide to adapt the SCAPE tool? Well, it was already being used in the acute service. It was a validated tool. It allowed our learning disability services to be included in measures within the acute services. So we are a health and social care service, so it allowed us to be looked at within the hospital, within how we are measured against our counterparts. It wasn't health separate to social care, it was all in together, all working together. But we do acknowledge there were a lot of changes. It was an acute tool and we did want to use it in a learning disability community setting, so we had to look at how we could change it. So this is what we did. Back in 2017 we formed a working group. We looked at the document and we tried to remove anything that said patient, anything that was really, really hospital based. So if it had the word ward, we tried to change it to area, department, home, and we took out patient and put in service user. So there were very obvious changes that needed to be made straight away. We discussed different things with each team, so we got people's feedback about this tool for the acute services. What do you reckon would need to be changed? We highlighted what SCAPE was about and why we wanted to implement it in learning disabilities. And then I also joined a couple of the acute SCAPEs so that I could see how they ran them, how they asked the questions. They split the tool into different colours so that different groups asked different questions. So it was also about how they used the tool and how on the day, and then how they went away and scored it. So we did try and get into some acute SCAPEs to see how they were working. So when we looked at the tool, we realised we needed a few more standards because it was very acute. So we invented the epilepsy care and treatment standard, the hospital care, health care for people with learning disabilities. So Sarah Lyle, I don't know if she's not here, is she? She's going to try. She wrote the epilepsy standard. So she looked at that because she has an interest in epilepsy. So we tried to get relevant people to write those standards from within the existing teams. We had Elaine Burgess and Jill from the Quality and Safety team come and meet some of the managers to explain SCAPE, to explain how it's been implemented in the hospital, the positives that had come out of it. And we also had Ellen Waring from the Lighthouse Wards come and talk to the managers as well, because she had just been awarded her first Blue SCAPE status within HSC. So she tried to explain to the teams how they had implemented it, what they had done, the feedback from her team about the positives, about getting that Blue SCAPE, and how she divvied up different parts of the standard so that everyone was involved. It wasn't just her as the manager trying to achieve everything, it was a team approach. And there was a consultation period with the staff about the tool, and it took around a year to actually write this tool in the end, because we were constantly toing and froing back to the teams, making a few changes, getting someone else involved, having another look. So it took a long time to write all the standards. And then in 2018, we piloted. So it was our year pilot. We just went to every area and audited. We decided that we would have a quality and safety rep on the audit team and the practice development lead, which was me at the time, and try and be on every single audit to offer consistency. And we would have 2 volunteers from across the learning disability service. The reason we wanted 2 volunteers is so people could get used to the tool. So if we were auditing Chateau Rev, someone from Shotley Villa could come along, and so when Shotley had their SCAPE, they had already been involved in the team, so they knew what type of questions were going to be asked. They could learn from each other, pick up good practice, see how they needed to change their own paperwork. So it was the team approach of how can we change, but how not just about us going into each area, about areas seeing what they were each doing. So this is what the 2018 tool looked like. We added the 3 standards at the bottom: hospital care, epilepsy and health needs. The rest stayed the same, but we did remove a lot of the questions if they were too acute based. So those were the scores after the first year. We had 1 red, 5 amber and 3 green. So you can see that not all areas scored the same, so we could see the tool was picking different things up from different areas. It wasn't just everyone scoring green, it wasn't everyone scoring red, it seemed to work. So at the end of 2018, the team got together and we evaluated the tool, and the managers surprisingly decided they didn't want a pre-warn for 2019. They didn't want 24 hours notice, they just wanted us to show up on a Wednesday with our clipboards ready to score them, which surprised everyone, but it's because it causes stress to know for those 24 hours. They felt that they were running around trying to get everything in place, and they were never going to be able to do that. So it reduced their anxieties in a weird way. We decided a different tool was required for the community learning disability service. They don't have a property. It was a very different tool that was needed. It was more about outcomes, how quickly referrals were being seen. So we knew we had to look at that for 2019. We wanted greater planning and engagements from service users and their family members, still something we are aiming to do. We became more familiar with the tool. So at the start of 2018, we were brand new at auditing like this. Learning disabilities hadn't been audited for many years and never on this scale, I don't think. So we got used to the tool as the year went on. We knew what we were asking on the different questions and what we were looking at and where we would find that information. And we weren't as good as we hoped. So people didn't all score greens, which was quite difficult. As I've said, we hadn't been audited for many years. So that was a new learning process for us about taking that feedback on about what we needed to improve. So after we had a look at that 2018 tool and what we wanted to change, we introduced the 2019 tool. So that was after making those tweaks, not the 24 hours notice. We also wrote a brand new positive behaviour support standard. So we didn't unfortunately have a complete team to write it for the 2018, but for the 2019 we had a PBS lead who rewrote that standard properly for us, which is very, very, very bespoke to learning disabilities over here. We also looked at including the standards for profound and multiple learning disabilities, the PMLD standards that are just coming out of the UK now. It's a new tool that's been created. So we looked at which standards out of those we could pull out and put in the tool. So there were some tweaks. And so that's what the 2019 tool looked like for this year that we've been using. So what did we do next? So there was we still want greater service user and family involvement. That is always going to be the gold standard of how we are involving people. We're looking at how do we measure values and attitudes of staff. It's really, really difficult, and how do you measure that in an audit tool? So we're looking at how can we include people's attitudes. We want to look at how we more integrate the learning disability standards from the NHS improvement. And we want to try and further embed the SCAPE process into practice. We are also looking at having a separate tool for outreach services and for residential services, because we've discovered this year that the way the services are evolving, outreach services are changing rapidly. They're taking a lot more cases on that the residential tool doesn't really fit anymore. So we're also looking at how we can change that. And this is our overall how we've done for the last 2 years. So you can see that the scores are varied in different areas. They aren't all the same. They change year by year as well for the same areas. So I think the tool is working, so it is picking up things. Not everyone is the same. And that's me done in a whirlwind.